Hello, everyone. I am your host, Chris Marchack, and welcome to our Clinical Chats, episode 54, where we hope to enlighten, entertain, and educate you on all topics in the field of dentistry. Please be aware that we are unable to see or hear you, but we encourage your participation and are happy to address any questions you may have. Simply click on the question and answer, the Q&A button located on the right-hand side of your screen. We will make every effort to answer them during the webinar. Rather than having a designated Q&A time, we aim to integrate your questions and comments throughout the session to maintain an engaging and interactive experience. Please feel free to submit your questions whenever they arise. The CE department credit will be sent to the email address you have provided within 48 hours, and this session will be accessible on demand in the coming days. Now, on with our program. For those of you who have joined us before, you will know my two dear friends and co-hosts, Dr. Frank Vidjak, prosthetist in Beverly Hills, Dr. Brian Goodacre, prosthetist in Upland, California, and the Director of Clinical Technologies for Noble Biocare. Hey, Frank, Brian, great to see you both.
Good to see you. Great to be with both of you.
Always fun. Looking forward to it.
Hey, Brian, where are you this week?
Thankfully, I'm at home, so it's nice to be at home.
I bet your wife and kids enjoy that. Hey, for this episode, I'd like to chat about immediate loading of the fully edentulous arch. Part 2. Brian, last month you're out of the country and you couldn't be with us, and we had a great program with Dr. Peter Moy about immediate loading on the surgical side. There was so much to talk about, Frank, wasn't there? There's so much to talk about, and I thought we would break this up into the restorative side. When to do it, why to do it, what to look out for. Is there any difference between immediate loading for healed jaws versus extraction sites, placement, load, and also any tips that we have for everyone. But before we go on to that chat, let's launch our initial poll. I want to know how you fabricate immediate load provisional restorations. So this is out to the audience. 1, I personally fabricate the provisional restoration at the time of implant placement, and that is the doctor doing that myself. Or 2, I prefabricate a provisional restoration and insert it at the time of surgery. Or 3, I use the services of a dental laboratory to fabricate my provisional restorations and insert it later in the day or that day. So as we wait for the results of that poll, Ruby, if we can have the slides, I'd like to first, I want to give a little homage to my dear friend, our dear friends, Dr. Tom Balshi, because he is actually the first one to report and discuss the conversion prosthesis. And this goes back, it was in Quintessence 1985, where he took a denture and actually converted the denture onto the implants, and hence this all kind of graduated into his techniques of teeth in a day, and many of the things that we see on commercials every morning was really started by this gentleman. Frank, I'm going to turn to you first. What are your initial thoughts about creating this provisional restoration and prosthesis? In other words, what do you do? What do you need? And what are your thoughts about this? Are they similar to what Dr. Balshi had done?
Well, now I'm looking at I don't feel as bad when I see 1985, but it only makes me feel a little less because the first one, because it really, you're turning back the clock in this whole topic that we're covering today. And I remember starting the first one for myself in 1999 and then got it published in 2000. And it was along these lines. But there's so much more that I'm sure we're going to get into later about how this even happened. Okay. Because right now, the bulk of the dental professionals, their beginning of their history is so different from, I'm going to leave you out, Chris. Okay. I'm going to respect the timeline on you, but it's really evolved, because what we talked about the last chat and the technologies and techniques involved as it's more commonplace today wasn't even a dream at that time. Yeah. So throughout today's chat, we're gonna get this dribbled in a little bit in comparison. So yeah, this brings back memories, but I can't say it doesn't bring back current memories as well. So I'll just leave it at that.
Now, Brian, how about you? How are you doing this? What is, let's just say you're the newer generation here.
To me, I think that what's kind of funny with it is, I hate to say it, this article is older than me. Is the funny part. So, that's the funny part. Yeah. It's a year older than me, so that's kind of funny. But the reality is, when you see those things that were done early on, it's kind of reminds you how, at that point, like, it's easy for me to come and do this procedure because we have decades worth of experience from, examples like Dr. Balshi, where we feel a lot more confident to do this. But I can't imagine trying to do that early on, not knowing if it's going to work or not. That's what's kind of, that's kind of hard to imagine being able to take that step, do a conversion like that immediately on implants. That's it takes a lot. Whereas for me, I've always known it can work because others have done it before me. So.
Well, the other thing we have to remember too, we had boundaries then. It was mental foramen.
Yeah.
It was like this to think about going posterior to it.
That's
85. That just barely we were allowed to utilize dental implants in this country. It was just barely.
Yeah.
So times have moved on.
If we look at our poll right now, number one of personally fabricating it yourself at the time of implant placement, 28%. B, fabricating it and inserting, prefabricating is 29%. And I'd like to talk more about that. And C, using the services of a dental laboratory to fabricate the provisional, 43%. Doing it later in the day or the next day. What's your thoughts about that, Brian?
I think that it's kind of what I would actually expect, because I know, it's a big part of I know a lot of surgeons, periodontist, oral surgeons, that will use a laboratory to come in and do a conversion. And it to me makes sense I guess the way I look at it is, if you don't have a comfort level from the restorative side as much, right, which is kind of that way, you would want someone to come and help do that, because it's not always logistically that easy for a surgical side to send the patient to their restorative dentist to do this. But it's definitely, that's kind of what I would expect, honestly.
I have to say that one of the things is this definition that I put into many of my lectures about what immediate loading is. And immediate loading truly is, there's a time period about this, and inserting it at the time of surgery or shortly thereafter. What is your thoughts about shortly thereafter?
I personally am the type that I prefer to do that the same day the implants are put in. And that's a couple reasons. My practice schedules are probably different than most. So I'm not actually in my office the next day. So I don't have a luxury of like bring them in the next day. But number two is, it's nice when they're numb. Swelling hasn't started to kick in as much. And so it's kind of, a little bit more convenient to attach it the same day. But you have to schedule accordingly, and, conversions, depending on how you do it, which I know we're going to talk more about, sometimes take a lot longer than you think. So
Frank, have you delivered a prosthesis the day after?
A fixed prosthesis? No.
A provisional fixed prosthesis?
Yeah, provisional, no.
Yeah.
It's been when I've done it, it's the same day.
Yeah.
Yeah, so I mean that's been my general rule, because if it didn't go in the day of the surgery, if for various reasons, and we'll talk about it later, but if somebody leaves even with a complete denture, they leave it out for more than 10 minutes the next day, I mean, they're not getting that back in. So things change very quickly. It's very dynamic, and pain threshold is really an issue, and you don't know really on any given person what that level is. So I shoot for the same day.
I shoot for the same day. I'm in the same agreement with both of you. I can just imagine what it's like to deliver a prosthesis, trying to get that patient anesthetized the next day. I've never done it. I just think it's just difficult. No? Yeah. I
mean, look, even the same day, we're not gonna kid ourselves. You have bleeding going on. I mean, the field is not the easiest thing to deal with. I mean, and that's something somebody has to think about if they're treatment planning this, and that's why medical history is so critical. You can stop certain meds, but it doesn't mean all the effects of those medications are eliminated like within 3 days, 5 days, whatever the stoppage period is. And we've all seen the Red River, and you've tried to deal with it, and it gets to be a challenge. So one has to be as prepared as possible.
We'd love to hear from the participants in the audience today. What your thoughts are about this. Please give in your comments, any suggestions, because I know that it is, as Brian said, a commonplace to have the dental laboratory fabricate it and come back in and doing it. But I've never done it that way. I'd be flat out honest. I've always made every one of them myself. So one of the things that I wanted to do as we move on to through this topic is I wanted to bring it down into 3 separate topics, or 3 different sections. 1, what do you need to fabricate at the time of implant placement, especially the aesthetics and the occlusion? How do we need to manage that? 2, can we or how do we prefabricate a provisional prosthesis? What is the downside, and how do you make it more predictable? Can we do this as prefabrication? And what about our laboratories doing it? What are your concern issues? And so if we can just kind of start with this, because when we look at this, we have this nice surgery was done with Dr. Peter Moy. And after he's finished placing all these implants, for me to fabricate that provisional restoration, how do we need to manage and do it? We have a few different comments here. Do you prefer to pick up the cylinders directly in the mouth, or use impression copings and make an analog model and do the conversion as a lab procedure? And Frank, this is a very good friend of yours and mine, and Brian, maybe you know him as well, Victor Rodriguez. Victor, great to hear from you. I miss seeing your car at our Cars and Coffee. Love to have you out. But Victor has worked with many surgeons and done that. Any thoughts? Any one of you? Brian, Frank, what's your thought about doing this?
Well, who wants to go first? I mean, since I'm talking,
Go
I
right
guess I
ahead,
will.
Brian. Frank, go ahead, Frank.
Go.
Yeah, I mean, having the thought of a dry field, meaning in the laboratory, on a gypsum cast, sounds like a reasonable one and something that could be utilized. I've never utilized that. My main concern would be, as much as you try to control the flow of the material, I'm dealing with an open wound, and I wouldn't want to take the risk of injecting, any kind of impression material, which at that point could become a filler. And I don't want to run that risk. And quite frankly, I haven't had the need to do that. But it's a viable method if somebody wants to manage that. But no, let's see, we're bringing up two different things though, because one has to think, how are you even getting to making this decision? Because in the poll, whether you make it yourself, the provisional restoration, the fixed restoration, or
Yes.
you have the lab do it, but the lab can't just pull something out of the hat. They
Right.
have to have some sort of information to go with. So what we need to, kind of break it down is who utilizes guided implant placement versus who still, because there's still surgeons, many of them, and I've said this before, just like digital radiography is pretty much standard of care, you can still go to a lot of dental practices in this country and they're using emulsion film. And it's not saying it's bad, but it's just like saying, do you see every surgeon, whatever background, or general dentist to specialists, will want to do implant surgery? They'll still maybe have some rudimentary guide, maybe, and then not knowing exactly where the implants are going to land. And then by default, that's going to bring up a different way how you come up with a fixed provisional. Because when I first did it, usually the surgeon, you make a surgical guide, but it never got dirty because they never put it in. You remember, it was like, well, we're going to put it where the bone is. That was the mantra of the time. So I never knew what I was going to get back. So good luck at trying to have a laboratory prefabricate one for you then. Okay. So information is different today. How you transmit it and what you do with it is very different. So a person has to know how they're going to approach that treatment.
So we have a comment here about photogrammetry. We'll talk about that later on today, because not everybody do we have the access to those units and so forth, but I would like to discuss that later on, and I'm going to hit up for you, Brian, so get prepared about that. But let's talk about the old techniques. How about you, Brian? What's some of your thoughts about this?
I think there's from the side of doing the conversion, like I still I love the idea, at least for me. I still do kind of the pre-planned is tough, is how I look at it, because a lot of the surgeon side, what we end up seeing is, a lot of them, they want like a duplicate denture with a trough cut in it so that they can stay within a certain area. And so I think when you try to prefabricate, it can be really hard to have like the channels already, the holes cut you can do, but having it actually ready to connect to the multi-units is almost impossible because you have so many variations. Even with guided surgery, that's kind of tricky. So I don't know if that, to me, I find that I tend to do a more conventional way with conversion currently. And I know we're going to talk photogrammetry, and that's something that I think has a lot of great benefits. But I think what I find is when you do a conversion, it really comes down to your comfort level of removable, because basically you're working with a denture in some form, whether it's a traditional denture or if it's some modified version of that. And I think that's why when we talk about how different people will do these conversions, bringing in laboratories, a lot of times it's when you don't have as much comfort with removable, you need that help and support. And that's why I think it's so popular.
I'll add and put my 2 cents about this, because I do a lot of immediate provisionalizations and picking up myself. as an armamentarium, what I want is I really need to have that denture, just like what Tom Balshe did. And with the computerized or digital dentures and abilities, and companies able to fabricate a framework for you and actually merge in the planning data, you can have everything preset and open and still have a palette there. I think that's makes things so much easier and makes things great. I also want to use temporary cylinders that are metal. I don't like plastic or PMMA ones because they're not, you can't see it radiographically. I want to make sure how they're sitting, how they're feeling. I've got something rigid and solid. And you might ask, well, how do you get this to stick? Well, I always place in, I sandblast them and then place a composite resin opaquer around it. And then I would add an adhesive to it. And Frank, I agree with you. I don't want to make impressions. I put those temporary cylinders right onto the implant, clear out everything, make sure it's not touching, and visually look, am I okay? Where am I setting? Where's my occlusal plane? What's the smile line like? And then I just tack them on. I don't go in and I try to fill everything in. I don't do that at that time. I just want to pick up the positions with, and I use a BIS GMA because it's so much easier in doing that. And then I would go into the laboratory after picking them all up, put in implant replicas, abutment replicas, and put it in quick set impression plaster first thing. Because if I don't do that, how many times have you broken or something has failed and you got to go back into the patient? I don't want to do that.
Oh, come on.
You know that happens. But as soon as you have that, into a index, you have a verified index, and you can start to make it from there.
Well, I do know that it's extremely common to have like a lab, and you see so many different variations from many well-known people that do a lot of conversions where they like to do some form of like a putty impression or something to pick up, and then allows them to do the final conversion very dense in some type of either pressure pot or things where they can control a lot more. And so, I think there's some nice things about that. I just get a little nervous of not picking it up chair side, like you said, because I want to make sure if it's the maxilla, I've got my occlusal plane, everything's kind of dialed in. And, the other part of it is, occlusion if you do both arches, right? And again, there's a lot of ideas of, hey, do one arch at a time because it makes your life easier. Doing two arches, I mean, I've done this.
Two times the problems.
Yeah. And then of course you're always crossing your fingers when the patient bites down the first time that they actually hit where they're supposed to. So it can definitely be nice to work outside the mouth, but I feel like I have better results when I pick that up clinically, where I've visually seen it, and then. Like you said, you have maybe outside the mouth finish it, but at least pick it up initially. Chair side.
Agreed.
Yeah. I think a lot of what both of you are saying is making sure you get oriented, that you have a compass, that you don't lose your situational awareness, because it's so easy to get wrapped up in things and, oh, I have to make space, this temporary abutment's over here, and let me connect it. And then all of a sudden you get smile, and then you see where you got so focused in one little area that when you broaden your view, oh my God, the occlusal plane got out of control. But of course that never happens to us, right? And that's why you heard Chris say, tack it in, don't just fill it and zap it, because cutting around all of that gets to be pretty problematic. But this begs a couple of things for me to hear from you, because I love hearing both of your feedback. But as part of that orientation process, that maxillary arch, because let's face it, something has to give us guidance.
Yeah.
We're primarily been referring to a twin fixed prosthesis, one maxillary, one mandibular, right? Two at the same time.
Yes.
But there's also going to be a staggering, maybe, because what if there's an issue with the patient? Because we've had that come up. We feel like everybody can handle 2 arches at the same time, but I don't know about you, if every single patient was able to handle 2 arches at the same time. Some, because of physicians' request, they asked that just treat 1 arch at a time. Okay, now for medical safety, okay, you're going to consider, well, what's that make you do? That makes you think out of the box. Okay, now does that happen often? Not that often. But again, Chris, you alluded to a denture. That palate gives you orientation.
It does.
Because if you didn't have that, then you could really manipulate that in any given way, unless you had an opposing matrix that you knew was going to be able to hold you in place. And then I know we'll discuss this on how you keep that orientation. But my other comment was going to be, in your treatment planning, I know you both do this, but it's so critical in the planning phases to be with, whether it's a team approach and there's a surgical colleague and then you have the restorative individual, that you understand what system is going to be used, what implant system is there, what components are available. Are you going to connect directly to the implant, or are you going to have a multi-unit type abutment? Okay, you need to know where that final prosthesis is going, so your interim restoration is going to mimic that. And so at the time of when you decide to do a conversion or laboratory fabricated, you know where you're going.
We've got a lot of questions and topics and some very good things about occlusion here, but I want to ask 2 things or make 2 statements in regards to this. Frank, one of the things that I remember in the program, in doing some of these things, we're always working behind the patient, right? Or to pick up things. And typically, I think one of the things is, don't forget to stand in front of the patient sometimes. Look at the patient, find out where you're at is an orientation. Quick question for both of you guys, and then let's hit some of these questions, because I think these are really important. And that is timing. How long does it take for you to do 1 arch? Because that's part of it too. How's the timing between the surgeon putting in the implants and then coming in and picking this up? Any thoughts about that?
I know what we do in the office with the oral surgeon that we work with locally is that we'll plan for, by 10 o'clock is traditionally what will happen, that the patient will arrive at our office. So, early surgery, they do everything, and then they let us know when they're on their way. But we plan about 10 o'clock so that we schedule, so I can see a few patients before the 10 o'clock patient comes in. And then I traditionally do about, in theory, again, I wish I could say I'm always this way, but about an hour an arch is what I try. Now, there are many examples where it was more than that. So, by all means, that's not a guarantee, but that's what I like. I mean, I'll plan 2 hours in the schedule, but, give myself a buffer, but it's about an hour from pickup, finish, adjust, polish, everything, kind of ready for the
Man, you're fast.
Yeah. But again, like I said, there are many examples where I have gone all over. So I have one on Monday, and I'll tell you on Monday.
We'll talk at the summit, okay?
I'll let you know if I made an hour or if I made I don't know. So.
I mean, I've always estimated between the surgeon, and many times I'm at the surgeon's office, so the patient doesn't have to travel, because that's really hard. A lot of the oral surgeons, the patients want to be sedated, and how do they come in and all that. I'm always allotting half a day for implant placement and restoration, or provisional restoration. I don't know. Frank, any thoughts on that?
Yeah, it's about that. For me, in my own practice, these appointments are pretty intense for the patient, and they're pretty intense for us. I don't do anything.
Absolutely.
I don't have anybody scheduled.
I have no one
scheduled. Someone of this nature, because for the what ifs, because if everything breaks loose, like wild horses,
Yeah.
I don't want the pressure of anything. Now, it may sound like, oh my God, what a long day for these individuals. Yes, it is. But again, it's not every day. Number two, I haven't had any of them yet not be sedated for this in one form or another. So by the time they come and see me, I need them for a period of time. If you were actually tie up that time of actual chair side, I would say probably anywhere between an hour and 15 minutes, hour and a half. I'm with them literally there. The rest of the time, I'm making dust in the lab.
Yeah.
So I have somebody there with them. They're usually asleep. Okay. And it's a good time at that point. I have somebody there to help them with ice packs and, kind of keep them comfortable. And they're usually snoozing. So it's more on us to get that all taken care of.
This is just a statement because he's a good friend and been on the program with us, Dr. Harel Simon. He wants to say hello to everybody.
Hi, Harel.
He says that I have always done the conversion prosthesis directly intraorally by myself. But if you have to work at the surgeon's office, it becomes logistically difficult, in which we all agree, because we got to carry all of our stuff over there, unless they have a full laboratory. It is actually a pleasure working with a skilled technician at the surgeon's office because some of them carry their own mobile laboratory, is what he says.
Yeah.
Interesting. There's a couple questions about occlusion. One is from Dr. Steven Silberg. He says, how are you going to find a treatment position or a centric relation position, and what position are you using? Frank, Brian, one of you want to take that?
I'll take my perspective, or it doesn't matter. But I like centric relation for me, but I also use some type of a jig. So if there is an adapted position for a person, right, you have to make this jig before, obviously, and they can help you orient. But for me, it's centric relation because a lot of times, if you think about it, they're sedated or sleeping, and so you're trying to find a position that's repeatable. And so for me, that's the only thing that's repeatable for me. Any of these adapted positions are tough because that's directed by the patient, who, especially if they're still sedated, you're in big trouble. So, yeah.
I think that's a great question.
It is a great question.
I think that just brings up the bigger picture of all of this, because we've talked about this before.
Mm-hmm.
If you actually would go to a final restoration, because there's exposure out there about saying, well, you can just go and have a guided surgery and have the actual restoration ready to rock and roll. Well, we know that it's a fluid situation, especially under the surgical conditions. Patients sedated, they're not totally there. How do you know where the mandible is really going to be? And that's where even though someone is going to argue, and they're right, if everything has an incision, and if there are components at that point, when you see, like I see the patient with healing abutments, okay, they don't come with anything. If there's going to be multi-unit abutments, I'm the one that places them. Okay, so it comes down to, yes, you modify in most of the cases, yes, it's some form of complete denture. We haven't touched yet about immediate, extraction, immediate placement, and all that. But right now, you're starting out with a nice removable restoration. Well, you have something to start with because you have something on the palate. Everything else may have been altered. You can't look at vestibules anymore. The ridge now has been modified, but at least the palate is somewhat consistent. Okay. I'm not going to say that I'm getting the perfect occlusion when we do this. That's far from the point I ever make.
I agree with you.
You give them something to start with, and that's where the follow-ups come.
Absolutely.
Amazingly enough, it's not that far off.
That's
it's not
far
like
off.
we're not grinding them flat. I think you both would agree.
Yeah.
The process seems to work. Okay,
Yes.
despite the conditions, it seems to work. But the question is great, because if we're looking at traditional, let's say on the West Coast here, because I know that all of us are worried about stable occlusion. We all will have a certain philosophy that we gravitate toward. The one thing that's common amongst all of them is stability.
Yep.
Okay, and distribution
Absolutely.
of forces,
Absolutely.
force management, right?
Yep.
So
Yep.
that being said, we will refine it as time goes by. We evaluate it.
I completely agree with you, Frank, because it's not going to happen that day. And when you're going through all this is not going to happen, especially when the patient is sedated. I think I want the patients to leave with bilateral contacts.
Uh-huh.
And that's it. I just want nice, even.
That's right.
Nice, even
And
bilateral
they
contacts.
They don't hit
Exactly.
in the second.
Exactly. Exactly. I mean, you know what I mean by bilateral contacts. I don't want to
just teasing. You're right.
because this comes up to a question that Victor Rodriguez has, and he just asked: when converging double arches, how do you control the occlusal plane and keep correct VDO and VDR so you don't change the vertical dimension? Are you too open or too closed? And for me, as long as I'm not open, we can err of being too closed. I'm okay with that. You know, because then that just develops more of a speech issues, other things. But as long as we're not too far open and having bilateral contacts. And Frank, as I mentioned, as you mentioned, it's the follow-up where we start to refine things and get things better. You want to just get this in, get it done, and start to refine the occlusion later. So
this is all circling around us clinically doing this the day of. Okay, that's where this conversation is coming in. And later, when Brian talks about the flag systems and all that, because then I have an example on that. So because that kind of changes potentially changes how much refinement goes into it over time. But to me, the digital still doesn't change us from having to track it, check it, correct it.
Absolutely.
Yeah,
absolutely.
Absolutely. This is a comment here. Human Zarenkov, he says, speed is the key to success. So I gotta love that. One question here is, do you cut out the palate in the provisional after picking up the implant positions? I always do. Absolutely. Get rid of it. Yep.
That's my compass.
That is. As once it's in and I find out where I'm at, then I'm okay. Sometimes if we're doing dual arches, I will make a bite registration so I can transfer it over onto an articulator so I can get the occlusion down to where I think it's appropriate. So Steve Lewis, our dear friend Steve Lewis, he has a quick comment. Hi, Steve. I make an impression first, pour the cast, then I pick up 2 cylinders intraorally. That allows the prosthesis to fit securely and properly on the cast, in additional cylinders and finishing. Plus, I have a cast in the case for future repairs. Absolutely. You want something if you need to repair something later on.
It's a great way to it's a great way to do it. It's a great way to do it. No question.
Absolutely. Absolutely. Ron Koslowski, he asked, after the tack-in with the rigid chairside material, do you use a conventional auto-polymerizing acrylic resin to fill in the space in the laboratory? Brian, do you want to respond to that?
For me, if I'm using a denture PMMA, okay, let's just say, whatever, most likely for me, again, it's a milled denture as an example. I personally, even though it takes longer, I do like a denture repair resin or something that actually chemically bonds to PMMA. I have nothing wrong with the, bisacryls and different things. I like the idea of knowing I have more than just mechanical locking. And yes, you can put like you said, a primer, and we can do that as well. But for some reason, I've always liked the idea of a chemical kind of bond, like locator abutments. I still attach with denture repair resin. I know there's many other materials, but it's just for whatever reason, it's worked well for me. And so it's hard for me to jump, even though it takes me, 4 minutes longer maybe than than some of the other materials. I'm accustomed to that. So maybe old school.
Frank, what do you use?
I'll use autopolymerizing resin, PMMA, for the same reasons. It's tried and true. It's so easy to work with, and when you're looking at relative time, I understand at the moment we get focused on the time, but we have to also think about, is it predictable what we're doing and working with? And you're dealing with something that, as far as the patient is concerned, you're creating a second set of teeth for them. This is their emergency kit. And this is the most important thing. When I get a patient saying to me, well, why do I have to do this? Just leave me with my dentures, and then, well, the dentures are your backup. Why do you want removable teeth? Because then you already have the basis for the fixed prosthesis, the fixed provisional. And then they're thinking, my God, yeah, you're right. This is the best possible backup I could ever have. And that's where later, I think you probably do the same thing. I make sure that the provisional restorations will interchangeably switch with the final, so that if something happens, God forbid, it never does, right, guys? Something bad with the final restoration never happens. So if you need to swap them out, see, that's where time really is king, because the patient's already stressed out. Unscrew the problematic restoration and put in the provisional, and it's literally minutes, and the patient's out and running, and they see the time and expense, so worth it.
Now, Brian, as we move on, how about prefabricating a provisional prosthesis? If I can show my slides here, Ruby, many of the things we're doing is using DTX to plan for the implants. We're using guides, and initially with the Nobel guide system, we can actually fabricate a cast in a predetermined space based on that surgical template. And what I do is I actually take a prosthesis and I get everything all set up, as you see in this slide here. What are your thoughts? What's the good and bad about this?
What's good about it is obviously it saves you a lot of time. So having these pre cut dentures really saves you a significant amount of time. So that's huge. Downside would be if that's your only prosthesis, and heaven forbid you don't get stability and you can't do a conversion, right? Again, honestly doesn't happen that frequently, in all honesty, but it can, right? We still tell our patients about it. It definitely is a discussion point. Then you'd have an issue if that was your only, like, let's say if you only made one prosthesis and you cut all these holes in it. Well, now you'd have to fill those to make it a functioning denture if you had to go that route. So that would be one negative to that process. But again, with guided surgery, the pictures you have here, right, it gets you in the ballpark, right? So you're going to pretty darn close. I'm not going to go ahead and pre-attach my temp cylinders, because there's going to be some play in that, right? So I don't go that far, but having the shell there is a great way. And even when you look today at all the stackable guides and different ways you can do this, you'll still, even with stackable guides, bone reduction guide, the whole, multiple stackable guides, they all still will have the final prosthesis with a decent size opening, because they know there's some play in that. So I think that kind of lets us know that, hey, it's a great way to do it. But the only downside I see is if you didn't get implant stability and you couldn't convert and you didn't have an actual backup denture, you were thinking this would be your backup. Well, now you got a problem because you don't have a denture. You got holes in it, and so you have no retention whatsoever.
How about you, Frank? Have you tried this before?
Yeah, well, in this mechanism, I haven't. Because typically what ends up for me is I'll get with the healing abutments, the patient comes back to me and with some sort of silicone indicating material, I'll perforate it, and it doesn't take me that long to get into the ballpark. And that way I'm utilizing, number one, if I'm able, like Brian said, it's nice to think that every time you're going to have the potential for a fixed restoration. There's been some some hiccups, and if the surgeon doesn't feel that it's appropriate, all of a sudden there's no immediate load. Okay, and then like Chris said, do you really want to have holes in the primary denture already? Well, I've avoided it because I don't do it until the moment of. And doing it the way it is on the cast, yeah, that saves some time. There's no doubt about it. But for me to use a large acrylic burr, and once I have those healing abutments marked in there, bore it through, it's not that much more time for me. And that way, I've modified it when I know I need to modify the denture and I can move forward. If not, patient goes home with Viscogel.
You both are going to think I'm crazy, but I actually prefabricated this all the way to the implant. But you'll see one thing here, as I seated it, some didn't fit, of course, because there's some degree of air. But I'm not sure if you notice this, but do you see the vertical slats around tooth number 7? That's because I had to cut it, section it, readjust everything, and then bond it back. So the question becomes, is it faster to pick up, or is it faster to cut and reattach? And so it's 50-50 in way it goes with that. We have a comment here and a real question is from Dennis Nagata. I know it's a patient specific, but are you heading towards more full zirconia dentures or prostheses versus an acrylic denture or a metal and resin fixed complete denture with a titanium frame? Any thoughts about those, guys?
Definitely more zirconia for me, so than metal acrylic personally. So,
Frank?
It's just like digital. Digital takes us into a certain direction, and with that comes certain materials.
Yeah.
And it seems zirconia seems to be working out, but at the same time, zirconia what? Monolithic zirconia with cemented abutments, cylinders, or do you have a titanium bar and then the zirconia superstructure cemented onto that? So when the word zirconia is used, it's not always zirconia. Is it zirconia to the abutment, and just no metal components at all? I mean, you can take this to whatever level, and each one has its pluses, it has its minuses. So that's a hard question to answer.
I love that you bring that up, Frank, because and it's perfect question and timing, because our next clinical chat is a comeback of fractured zirconia prostheses, and so this is perfect. I want you to remember what you just said there, Frank, and let's expand on that a little bit further. But I would have to, for me, I agree with you, Brian. I'm leaning more towards zirconia prostheses because of the issues with wear fractures of denture teeth and as it wears. So as we look at this, we have also time here, because I like to spend a little bit of time on photogrammetry or laboratory fabricated types of prostheses? Do we scan? Brian, what's your thoughts about this, of having this made, and have you had any experience with it?
So photogrammetry side, using like the
Or maybe,
iCam.
yeah, and maybe you can explain a little bit about photogrammetry also, please.
Yeah, so I mean, the nicest part with it, and I have a patient that I went through both conventional and photogrammetry with. This was more focused on going from a conversion to final. So it's not necessarily conversion like we're talking about here, but we'll talk about that in 1 second. But what's very impressive is the savings of time, chair side. And like, I need to go back and look because I recorded the whole thing. So I have like the exact time I spent in the mouth, and I need to go and actually calculate this. It would be interesting. But the photogrammetry side, you know, again, this is a conversion to final, but you intraorally scan the conversion prosthesis with the palette as an example. You scan the opposing arch, if we're doing dual arch or one arch, whatever. Then you get your interocclusal record with the conversion prosthesis. You then take the prosthesis out, put these flags. Again, there's different types of flags. The ones that look like kind of a domino in the back is one example. There's other types. And you then photogrammetry, you calibrate your scanner, you scan the patient literally, you know, less than 30 seconds, you're done, basically, you know, if you think about it. And then the last step you do is you scan the soft tissue. And when you scan the soft tissue, you do have to put these, you know, the white healing caps on, for example, multi-unit abutments, and you scan that. And with that, the lab can merge all these files together. And, you know, maybe that's something I can show in another time, but can show you that. But it's fascinating how they can take that. Now, the one thing I'll tell you with it, for the first 2 or 3 of them that I did, I still did the conventional impression because I had to physically see a physical cast to try the final prosthesis on, just for my mental understanding, which is funny. But so I did it. Now I stopped, but I had to do it for the first couple because it had been, before doing photogrammetry, I always had a verified cast that I could try the prosthesis on when I got it back. And so it took me a little bit to get past the idea that with photogrammetry, there's no verification cast or anything like that. So it's definitely something that took me a little bit, just ironically that I did it for a couple times and then you stopped, then I stopped. But when it comes to this, the time saving is just amazing what it takes. And when we're talking about a conversion prosthesis as the topic for today, what's fascinating with it is all the heavy lifting basically is done before the surgery takes place, right? So you intraorally scan the patient, you get whichever form of interocclusal record that you're deciding to do, and that information goes to the lab. They basically design a prototype. They have everything ready to go, except for they don't know where the soft tissue is going to end up or with where the implants will be. And what's great, and then what they do is you schedule this with the laboratory, whether it's in-house or whether it's you know, off-site, but you schedule ahead of time so that the day of surgery, implants go in, photogrammetry and a scan of the soft tissue, they can take and merge this data together. And it's a magical thing when you see it all come together. I'll tell you though, those that have done enough of it, you know, what's the real struggle still is your occlusion, because you all of a sudden your palate, when you in a healed situation, your palate's a decent, you know, reference, but after surgery, you've reflected tissue, you've injected anesthetic, there's swelling. It's not a great reference for occlusion. And so as a result of that, there are certain things you have to do at the time of surgery. So what you'll do is before the surgery starts, they traditionally will put some form of a reference, fiduciary marker, whether that's a screw into the palate, a couple places into the, you know, using anchor pins, using, you know, there's many techniques people will use to place these reference markers, but that's still one of the challenges is occlusion, because you can get the implant positions recorded very accurately, but now how you're relating the maxilla and the mandible together. And so that's still the one struggle area that I think some people, and again, I'm definitely not the expert on it, especially for the conversion prosthesis, but especially when I talk with those that do it basically almost a daily basis, that's the big struggle for them is occlusion still.
So this really comes up to a point of, you know, what is your protocols after the surgery? When do you see the patient next, and what are you looking for during the time of healing? Whether it is a prefabricated prosthesis, whatever provisional restoration, in immediate loading on the restorative side, what are we looking for, and what are we telling our patients they can do and not do?
Well, can I know, because we're running short of time, I just wanted to give an example with Brian, because in the images here, it's the tissues healed, but the one place that it is useful and to have photograph. Now I'm getting all tongue tied. Okay. Yeah. Okay, help me out here.
Photogrammetry. You got it.
Photogrammetry. Okay. Because I keep thinking of photography, photogrammetry. Okay. What's great is you can have a dental technician go to the surgeon's office at the time of surgery. And that's when I've employed this. And to clarify, when I do the conversion, it's the same day. I won't do a conversion the second day. This,
yes,
you can't help but have subsequent days. It can be the next day, it could be 48 hours later. And you'll have a provisional restoration ready. And I have to tell you, it took me a while to kind of soak this in, how somebody with an extraoral camera of sorts and with these flags in place can come up with something that can fit so well.
Yeah.
It's astounding. It truly is. But that's where I find this subsequent placement is possible. You can't, not going to do that the same day. Okay, not using photogrammetry, not the same day.
I really think that
some do it, but it's tough.
Yeah, it's hard. It's super hard.
I really think that's why it is so important that afterwards, it's your post-treatment follow-ups, making sure that the occlusion, how the patient is adapting to it, and other aspects, as well as we've talked about oral hygiene too. So,
well, who sees the patient more after the?
We do. We do.
It comes with our territory, right?
Yeah. Are you seeing the patients weekly afterwards or monthly? Or when are you changing the occlusions?
Well, I'll leave them alone for a couple of weeks, unless they call with a particular issue. But then if they're doing well at a couple of weeks, then I bounce it to 4.
Yeah.
And I just track them at that point.
I tend to see them once a week right after surgery. As soon as, if I can get them in as soon as possible, because I want that, check that occlusion, make sure I have bilateral posterior contacts. That's me personally, and then I check them, so make sure that they're not having this heavy chewing diet as well.
Yeah.
One time I had a patient come in. I said, "Hey, what was for dinner?" He goes, "Oh man, I had this great lamb pork chop." I'm like, "What are you doing?" Hey, this is a great topic. It's one of my passions in implant dentistry. I love making these. But one of the things that we have at the summit next month, if any of you are coming out, I'm talking about avoiding and managing prosthetic complications with this, and at the summit next month, and I'll be talking about immediate lobe provisional restorations. So if you want to come on out, come and join me, and we'll have a good chance to chat about that, and talk about it. If there is anything that you'd like to chat about, any of your cases, please feel free to email me your topic case to me at drchris@club32.com, and we can put that into our chat. And what would you do? I'd like to thank you, my two dear friends, Dr. Brian Goodacre, Dr. Frank Vidjak. It's always a pleasure and honor to sit down with this hour with you. I enjoy it so much, and I learned so much from the two of you as well. I want to wish you both both well, and thank you both for coming on. Our
Thank you.
next episode of Clinical Chats will be on Wednesday, March 13th, the second Wednesday of the month, at 5 p.m. So it's Wednesday, March 13th, the second Wednesday of the month at 5 p.m. Pacific time. And by popular demand, we're going to talk about, to continue our chat on the steps to prevent full arch zirconia fractures. And if we can have that QR code, if you want to go ahead and register now, here's a QR code for that registration link, or you can wait and watch out for your mailers in your inbox. And with that, with my utmost enthusiasm, I would like to extend my heartfelt gratitude to all of you, our beloved fans and viewers, to creating brilliant smiles that makes the world a brighter place. Stay well, my friends, and until we meet again, I look forward to seeing you next week, Brian and Frank. Look forward to seeing you sometime soon, hopefully before our next chat.
Looking forward to
Until
it.
we meet
Thank you,
again.
guys. Good seeing
Have a
you.
great evening,
night.
everyone.
You too. Bye-bye.
Thank you.
Are you guys there? Can you hear me?
I'm here.
Yeah,
It just
I'm
says
here.
streaming and recording.